Okay, hello everybody. So this is Intro to Physical Therapy again, and today is should be day 3. Today we're going to be going over chapter 3 in your book. This is going to be more about what you as a PTA are able to do and what the different areas of work that you can, not work, the different specialties and different niches you can go into. So we'll talk about that a little bit today. Excuse me. So let me share my screen. Okay. And you should have access to this PowerPoint on Blackboard as well. Okay, so the physical therapist assistant, where do I fit in? Okay, well, you know what physical therapy is, so I'm not going to read you this definition, but it is, look at the definition. I'll let you read the definition, but make sure that you don't just stop at optimal physical function and wellness. Make sure that you understand that physical therapy is a restoration to a function as it relates to somebody's life. So it could be something with their everyday life, it could be something with their job, but it's getting back to something that is meaningful for that person. That's what we mean by something that's functional. Okay. Okay, well, let's talk a little bit about physical therapists for a little bit. So now physical therapists out there have an entry level is a doctorate degree. It stands for DPT. Lots of us out there have the master's degree, and that's MPT. Has to be CAPTI approved, which we talked about CAPTI already. We're licensed. And then we can get clinical specialties too, through the American Board of Physical Therapy Specialties. Okay, now let's compare physical therapists to physical therapist assistants. You're professionally educated, still CAPTI approved. You have a physical PTAs have a license too. Still have to sit for that board exam and take your continuing education every 2 years. The difference is you work under the direct supervision of the PT. Now, that doesn't mean the PT is always going to be looking over your shoulder saying, what are you doing? Why are you doing this? But they're going to, the physical therapist has the last say so in the plan of care. The physical therapist writes the plan of care, but will get as you gain experience, your supervising therapist will give you a little bit more leeway at making decisions. But no matter how much experience you have, you always have to go by what the supervising physical therapist says. And anytime there's a patient change, that's something that's unexpected or something different with a patient, you always have to stop what you're doing. You can't treat anymore until you bring it up to the supervising physical therapist. That could be in the same clinic, just walk over and ask them. Or if you're working home health, you might have to call your supervising therapist. Okay, we did talk a little bit about the other day about how PTAs came into existence, but I talked about around 1965. That's when Medicare and Medicaid were written into law, and suddenly we had reimbursement was available for all of these older populations of people, but there were not enough PTs to equal the demand that was out there. So in 1964, the APTA started a committee to explore the possibility of creating the PTA position. And then in 1967, the first graduates from the first PTA program graduated. And this is a ratio from 1995. What's the ratio about right now of PTs to PTAs? PTAs to PTs? Okay, so we do have a few documents that guide our practice that we have to always go by. And I'm not talking about our textbooks, and I'm talking about things we learn in school, but these are things that govern our profession. And some of these are laws, and then others, these are guidelines. So first we have the Guide to Physical Therapist Practice. And you can read all of these. These are all of our documents that we have. We're going to go through some of these today, and then go through. Oh, excuse me, and then go through other ones later on in the semester. So what specialties or what areas can you go to work in? Well, you name it, It's out there. So you can work in acute care, which would be an inpatient hospital stay, where people may go and just stay for a few days before they leave. You may be, most of you are probably more familiar with the outpatient clinic. That's when you, that's more just, that's most of the physical therapy clinics and employees work in outpatient clinics. And that can be ortho outpatient, neuro outpatient, pediatric outpatient, you name it, it can be outpatient. Rehab facilities. So rehab is a little bit different than acute care. In rehab, you are inpatient, so you are staying there, and it could be a hospital or it could be a rehab facility, but you're there because you're too well to be in acute care, but you're still too injured or damaged or sick to go home. So this is like the middle stop. And in rehab, you may stay here 2 weeks, you may stay here 3 weeks. I've had, when I worked at Tier in the med center, I had a patient that stayed 8 months. From the time he got there to the time he left, and that was just his inpatient rehab. That doesn't count all the outpatient he went through. Now, that's not as common nowadays, but inpatient rehab, in rehab, you are inpatient, but you are a little bit better. You're just too good for acute, but not quite well enough to go home yet. Skilled nursing facilities. So a SNF, we say it, we pronounce this as a SNF, that stands for skilled nursing facility. So a skilled nursing facility is, say a person leaves rehab and they still need a little bit extra care, or they have nursing needs that can't be carried out at home or on a home health basis. So they'll go to a skilled nursing facility, which is very much like a nursing home, and many nursing homes are set up to be residential and if you're there for skilled nursing and for a SNF, you're supposed to be there for a short-term amount. Home health, you all are familiar with this probably. This is when you, as the PTA, would actually go out to the patient's home and treat them there. And that's a very popular job that PTs and PTAs go into. Most of the time, this is going to be with either pediatric clients or geriatric clients. So either the very, very young or the very, very old that can't really leave home. Or people get home health if it's too much of a burden for them physically and medically to leave the home. We can work in schools. So we can work in school, and a lot of times we don't work at one school. We may work, PTs or PTAs may work for a school district, or you may be in charge of 2 or 3 schools in that district. And we may do individual sessions. We may work with teachers on setting up special equipment and adaptive devices for their students so that they can participate with the class. We may work with PE teachers to make sure that that they're making their sports adaptive for the kids with disabilities. So making sure that they still can participate and get the same type of physical activity that their peers are getting, despite their physical or mental disability. So there's lots of different things that can be done in the school. We can work in corporate settings where we might be there for ergonomic and workspace management, or we may work in a corporate setting where we only see on-the-job injuries. Hospice is usually the end of the line for most people if they even go to hospice. But hospice is, if you don't know what a hospice is where you go when you're about to die and your condition is terminal, and you go there with the intention of living out your final weeks or month. And they're keeping you, it's usually run by nurses and a few doctors, and they're keeping you medically comfortable. They're letting you die with dignity. Okay. So you're not gonna, if you need pain medicine, they'll give you pain medicine, but there's really not gonna be, and we do work in those facilities with those patients, but we're not doing the type of therapy like strengthening and getting them independent with things. These people are terminal. I mean, they know they are going to die. We do know that these people are going to die soon, and so we're doing things also to keep them comfortable. So we may just do some simple passive range of motion for them and some stretching, just if they feel like they're getting tight, we may stretch them out. Maybe some simple exercises to keep them doing some things on their own, but it's going to be a lot of family education too about how to care for their family member while they're in that later stage of life. We can work with athletes and athletic facilities, with sports teams, high school teams, and PTAs can also work for fitness centers. So you can work for a gym and do training as a therapist, and that usual. And now you probably have to be have the trainer certification too, but trainers that are PTAs or PTs usually get a little bit more oomph to their name, because people say, oh, they have a healthcare degree too, and it's a physical healthcare degree, so they probably know a lot more about training than a regular personal trainer would. Okay, so what type of settings? More about the settings. So this would be a typical outpatient facility, just lots of different machines, tables of different heights. A lot of outpatient facilities have pools where we do aquatic therapy, and this lady is just doing some, looks like she's doing some upper extremity exercises in the water. This would be in acute care, and this looks more like the ICU. This would be a regular acute care bed or a rehab facility bed. This is going to be a place that is, and this looks just like a little rehab gym, like in a SNF or maybe a small outpatient gym, all the way up to high level activities. So you see these people are, you can see in the top picture, there's wheelchairs sitting around, but people have got out of the wheelchairs and they're on the floor and they're doing stuff. Then you see this guy over here on the bottom page, the bottom picture. If you look at his left leg closely, he's an amputee. He has a prosthetic on, but look at their walk wall he's climbing and how high he already is. So you'll see we work with people of all different levels of injury, all different diagnoses, all different walks of life. And it may take you a few jobs or a few years to find what you really, really like and the area you're passionate about. But most of us do, after a few years, find a certain population that we like working with, and it's kind of our favorite, and that becomes kind of our niche. This guy's using virtual reality, probably working on standing balance, and he's working on reaction time. So it looks like he's performing a shooting game. And if you wonder how that works on balance, we'll see that if you can see that harness is holding him up, he probably has to walk and he probably has to sidestep, and he's shooting from all directions. So that would throw anybody's balance off. So that harness is there to catch him. And this is a double amputee, and he's working on walking on unstable surfaces. So this would probably be an outpatient, but you can see he's walking on like a turf setting that's a little uneven. And then even next to him, there's rocks. Well, just to explain to what that is, this is just an example. It's awesome if we get people learning to walk again on level ground, like on tile or concrete. But once they get out of their house, all the world is uneven ground. Sidewalks are not level, driveways are not level, grass, even if it looks like it's a flatty surface, it's going to have little bitty ups and downs in it. So those are all unstable surfaces that we have to teach people to walk on, because that's everyday life. Pediatrics, anywhere from infants all the way up to all school ages. There's therapy on horseback, which is called hippotherapy. And hippotherapy is a really specialized niche of therapy that that not many people go into, just because I think probably the reimbursement and the cost of keeping the horses. But it is something that's used with peds a lot, and it does help them with their gait training a lot. And when I say gait training, I mean learning to walk and ambulate. Gait training means training to walk. Okay. Okay. So who do we treat? So we're going to be seeing people that we're not going to just be seeing people that need to get stronger or that want to work out. We're going to be seeing people that have a disease or disorder or a condition, and then they have some kind of physical impairment, which I will describe later, which gives them a functional limitation, and then that gives them some type of disability. So we'll talk about all those in a minute. The healthcare team is going to be made up of different people. So never consider yourself when you're treating a patient or a client working by, you're the only person there. There's going to be other disciplines involved. It could be OT, it could be speech. There's always going to be at least one doctor involved in their care. They could have a social worker or a case manager for their insurance. Maybe social work is helping them with other resources or with insurance things or with counseling. So there's always going to be a lot of team members. Well, when we say the words intradisciplinary, that means we're talking about just within one discipline. So if we were talking about PTs and PTAs, the things that we do, that's intradisciplinary. If we said interdisciplinary, that means more than one discipline working together on the same patient, either at the same time or at different times. So OTs and PTs could be seeing the patient at separate times, or they could be seeing OT and PT could co-treat and see the same person together at the same time. And multidisciplinary just means is just another way of saying interdisciplinary. There's lots of different disciplines involved. Okay, you know what PTAs and PTAs do. OTs and CODAs, CODA stands for Certified Occupational Therapy Assistant. Our worlds are very much overlapping, and our professions really stem from all the reconstruction aids that we talked about on day one. We did branch off a little bit, but they deal with more fine motor things, more activities of daily living, like getting dressed, cooking for yourself, bathing, cleaning yourself after going to the bathroom, hygiene, grooming, things like that. But they can still work on gait training. They can still work on stretching, strengthening, range of motion. So a lot of times you may see them and think, that's exactly what I do, but then they'll turn around and do something a little bit off the wall that you may not know what it is. And that's where we differ a little bit. Speech therapists work with speech, language, and cognition and memory. An orthotist is a person that makes like a brace that a person may wear, and a prosthetist is a person that makes an artificial limb. You know what a physician is. These are nurses, so a registered nurse. LPN is a nursing degree that is not they're not a registered nurse, but they do have basic medical training. They can still give things like injections and medications, but they can't do some of the things that RNs can do. And CNA stands for Certified Nursing Assistant. This is a nurse assistant or a nurse's aide. Social worker will help with insurance and counseling and education of the family. Athletic trainer. PTA, volunteer or student. This could be a tech or just a volunteer. Okay, physical therapist scope of practice. So this is going to be in one of one of the documents that we have available to us as a profession. It was the physical therapist scope of practice was developed by the APTA, and it tells us basically what things we can do and what we can't do as PTAs and PTs. It tells us the services that we're allowed to provide, the types of disabilities, and the types of things we're able to do. It addresses the risk that could happen, and it basically it's our bylaws that say these are the people you can treat, and this is what you can do with your degree. This is what you can't do. So that's basically all it says. So in one state, some states, their scope, the PTA scope of practice says that PTAs are not able to do joint mobilizations. Well, the Texas scope of practice says PTAs are allowed to do joint mobilizations. Now, the APTA discourages states from letting PTAs do joint mobs, but they still allow the states to make the call. Well, Texas has decided that in our state, we do allow PTAs to do joint mobilizations, which I think is very appropriate. In other states, they're not allowed to do joint mobilizations, and they would have to get their supervising therapist to do all the joint mobilizations, which is a lot of trouble. And really, you're skilled enough to do that. And if we teach you, then you know how to do it. So let's do it. So we'll let you do it. On the scope of practice, gives us guidelines on providing prevention for injuries and promoting health and wellness. And it helps direct and guide the supervising physical therapist. And it helps guides the PTA and aid and the tech in knowing what they can and can't do. On the scope of practice, each state has their own practice act. And you know this. So let's talk about a little bit of the differences in what PTs and what PTAs do, the differences. Not much of a difference, but the biggest thing that PTs can do that you can't do, we can diagnose. We can come up with a physical therapy diagnosis, and we can be a consultant for other disciplines. What do PTAs do? Well, you can perform all the PT interventions, exercises, modalities, things that PTs can do. You just can't do an evaluation. You can't make a diagnosis, and you can't make a recommendation on equipment. You can modify the plan of care interventions, but only if the PT has allowed you to do that in the written plan of care. So for example, if the PT put in the written plan of care, and plan of care is the part of the documentation that you would go to as a PTA, or even if I was a PT substituting, I would look at the plan of care to see what the patient is supposed to be working on, the goals and their activities that they've been doing. Well, if your supervising therapist has written perform electrical stimulation to the lower back, high rate tens, 4 milliamps max, then you are very much boxed in. You can only use that type of electrical stimulation in that particular body part on the lower back, and you can only go up to the intensity that 4 milliamps that the therapist told you to do. Don't worry about what those mean. You'll learn it in the second semester. But so if the therapist wrote it like that, if your supervisor wrote it like that, you can only do that. You can only do what the therapist wrote. You can't change it. But if your therapist said perform electrical stimulation to lower back for pain control, then that tells you I need to do electrical stimulation for pain control, but I can use TENS, I can use interferential, and I can change all the settings. And those are just two different types of stimulation. And you as the PTA have the choice and the freedom to change all the settings as you see fit. Now, you're going to know next semester, we're going to teach you all the settings for different modalities. So you would know what to use if the therapist gives you permission to make those modifications. And most of the time they will. Now, I will tell you, probably as new grads, your therapist your supervising and PTs will write you more direct instructions and kind of box you in more. But as they see you growing, and as you gain more experience and become more comfortable with things, and you let them know what you're comfortable with, then they'll start making the plan of care a little bit more open-ended so that you can make more decisions on your own. And you just have to build that trust with your supervisor. That's all it is. You also document every visit that we've had, whether it's a PT Senate, a PTA. We always have to document everything that we did. So we have to document anything about the person that they said to us. We have to document everything that we did. We have to document how the person responded and how they did with our activities. And then we have to plan based on that session. We have to make a plan for the next session. And all that is documented, every visit that we do, and every discipline documents. So no matter what medical discipline you are, all the way down from doctors, OTs, PTs, music therapists, recreation therapists, speech therapists, psychologists, we all document what we do. We all have to write down exactly what we do. That may be the activities that we do. We may be taking measurements of joint angles or strength measurements, and we're writing down scores and test scores, things like that. So all that is documentation. And we all educate too. So we educate our families on, people aren't going to be in therapy forever, so they have to eventually learn how to overcome things themselves or do the last bit of strengthening themselves. So we send everybody with a home exercise program. We have people start doing things on their own early on, even before therapy is done, to speed up therapy. And then we educate them. Maybe they have to learn how to get in and out of their wheelchair on their own. Well, that's a skill we teach. We may also teach the family members how to help them get in and out of the wheelchair or how to do their exercises. That's all education that we do. We teach a lot in our profession. Sometimes sometimes techs do routine operational duties around the clinic, but if mats need sanitizing, or if hot packs need cleaning, or laundry needs doing, sometimes we get stuck with that too. And it doesn't matter whether you're the PT or the PTA, you might get stuck with it. Usually it depends on how big your facility is. And even at PEMA, we're all PTs, but we take turns doing laundry. So don't think that you're getting less, don't feel like you're getting put down by doing the operational clinic duties. It just falls on all of us sometimes. That's what PTAs cannot do. Oops, sorry about that barking. Okay. So what PTAs cannot do, like I've told you, it varies state by the state. So like I told you, in some states, the Practice Act says that PTAs cannot do joint mobilizations. But in Texas, we do allow PTAs to do joint mobilizations. In some states, they don't let PTAs do any wound care things. But then in Texas, they do let PTAs do wound care. So, it just varies by state. You may not evaluate or reevaluate. So you can't do an initial evaluation and examination, and you can't do a reevaluation, which would be like a monthly, which is something that's done monthly or periodically to check the progress. You can't do reevaluations. Now, you could take some of the measurements for me and let me know, but I have to be, the PT has to be the one to write up the formal reevaluation. You can't come up with your own plan of care or change it or change the prescription plan. Now, remember, I said you could modify plan of care if the PTA makes it open-ended, but you may never blatantly change anything in the plan of care from what the PT says. You can never discharge a patient or write a discharge summary. So the last visit has to be seen with the PT, and they have to write the discharge summary. Now, you can give them information on how they've been doing in therapy, on the goals that they've met while they were in therapy, but the PT has to be the one to do the formal discharge summary. And I've already told you this. So PTA, PT relationship, yeah, you have to have a supervisor for all of your patients, but it's based, and you might not like that right now, but think about it like this. It's based on trust and respect. So it's just like any job you get. When you first get your first job out of school, you're probably going to have one or more than one supervising physical therapist. It depends on how many patients you have on your caseload, and it depends on how many PTAs they're supervising. I mean, it's just every facility is going to be a little bit different. But if you're a new grad and they're an experienced therapist, they may box you in with your plan of care a lot in the beginning. I mean, they may make it very rigid what they want you to do. until they start seeing what you're made of, what you're comfortable with, your skills and your gifts. And then they'll start giving you more leeway as they trust you. And also, as you work together with your supervising therapist, you start gaining mutual respect for one another, not just professionally with like, yes, I know how to do this, and I do know how to do this, I'm experienced in this, but also personally, because let's say if your personalities are always clashing, then they're probably never going to give you trust and respect. And they're probably never going to give you a lot of leeway with your patients. But if they trust you and you give each other respect reciprocally, and that goes both ways on both sides, then you'll develop a better relationship, and your working environment will just be much better, and you'll have your patient outcomes will be much better. They really will. It's always where this says need and appreciation for individual differences. You have got to learn how to work with other people in our profession. Yes, you're going to be working one-on-one with your patients a lot, but you don't realize now how much you're going to be working with other therapists on making decisions, with other types of therapists making decisions, with other PTAs and other PTs. You're going to be talking to doctors in person during rounds, or on the phone. You're going to be calling physicians one day, asking them about something. There's so many different kinds of personalities out there. Some personalities are very characteristic of certain disciplines. So some disciplines tend to look down on other disciplines, and sometimes you just have to gain a thick skin. But it's always good to always, no matter who you're talking to, let them know who you are, but don't try to be like a one-up them. Always give them the mutual respect that you would want them to give you professionally. So if you think that you are a good therapist, you may not know much about their work, but you need to treat them like they are a good worker, or they're a good therapist in their discipline, because you're working with the same patient. So you need to learn how to work together. And even if personalities clash, you've just got to bite the bullet and just be professional about it. Communication, I just really talked about it. Communication is very, very, very important. The guide to PT practice is just another reference that we have. Helps PTs enhance their quality of care, and PTAs. It's divided into two parts. So part one is more of like a description of different diagnoses, and then different ideas of things you can use for treatment. Now, it's not going to tell you, for example, total knee replacement, see them for 6 weeks, work on quad sets, work on hamstrings, work on these things. It's going to say total knee replacement, typically therapeutic exercise, neuromuscular re-education, balance training, that is needed. It's going to say things like that. But for practice patterns, is going to give you a little bit deeper into kind of like the way that you would typically see a patient or treat a patient. So a lot of new therapists may use this as a guide in the beginning to kind of see what preferred patterns are. But kind of think of the guide to PT practice as kind of like our Bible. A PT exam or eval is what the PT does, not the PTA. So it's going to include a thorough history of the patient and their social history. Systems review just means their health history. Test and measures means any measurements we take, strength measurements, walking time test, balance test, things like that. And that all is taken together and made into an evaluation, which we take, and that in the PT will make their clinical judgments based on the exam findings. So then we make a physical therapy diagnosis, which is usually going to be different than the medical diagnosis. Sometimes it is, sometimes it's not. And then we're going to list the impairments, the functional limitations, disabilities, their prognosis, and interventions. And we're going to go through all these one by one. So a physical therapy diagnosis is basically what we are treating. It may be different than the medical diagnosis. So a medical diagnosis is made by the doctor. and it's usually a disease or an injury or something that happened. So ligament sprain of the cruciate ligament of the knee, or muscular dystrophy. Those are pathologies. Those are diseases or injuries. So that's what a pathology is. A physical therapy diagnosis for sprain if their medical diagnosis may say sprain of the ligament of the knee. Well, if you sprain a ligament in your knee, you're going to have trouble walking. So our physical therapy diagnosis may be abnormality of gait, which means abnormality of walking or abnormal walking. For muscular dystrophy, that would be the pathology, the medical diagnosis. The physical therapy diagnosis might be lower extremity weakness or global muscle weakness. Okay. So the PT diagnosis is going to link impairments and functional deficits. Okay. So think of, when I said the word function before, function is something we do every day, or a movement or a pattern of movement or an activity that's important for our daily life. So let's look at this first example. Functional deficit, inability to put dishes away on the top of the cabinet. Well, if they can't do that, then that means that their impairments would be, it could be decreased shoulder, passive range of motion, just which means their flexibility. Maybe they don't have the range, or maybe they don't have the strength to reach up. So their impairment, so maybe their functional deficit is inability to put dishes away. That's their functional limitation, or that's their functional deficit. Their impairment is decreased strength, decreased flexibility, decreased range of motion. Let's look at example 2. Their functional deficit, which is an everyday activity, is inability to ambulate for distance to allow grocery shopping. So this person maybe can walk short distances, but they can't walk long enough to do a full grocery shopping trip. Well, then in our notes, we would list their impairments as maybe pain, decreased strength of the lower extremities. This is listing the gastroconsolius complex, which is a couple of muscles. So those are impairments. Okay, so the definition of an impairment is the alteration in an anatomical or physiological or structure that results in a pathology. So examples would be muscle weakness. Examples of impairments are muscle weakness, pain, decreased coordination, decreased range of motion, which you can think of as flexibility, increased inflammation of a body part is an impairment. Now you have to sprain an ankle and your ankle swells up, or decreased balance is an impairment. Now let's talk about functional limitations. You have to know the impairment to know what the functional limitation is. Okay, so the functional limitation is an individual's inability to perform a certain task or an obligation that that's part of their daily life. So an example, inability to ambulate, inability to walk. Well, we know an impairment would be decreased strength in the lower extremities, the legs. Well, the functional limitation would be inability to walk. Or if your impairment was weakness in your upper extremities, your functional limitation may be inability to wash hair. Your functional limitation could be inability to transfer self to and from a chair. Or if your impairment was lower extremity and trunk weakness, your functional limitation could be inability to stand. So functional limitations are actual things that are important that we do in our everyday life. So motor tasks that we usually do. Well, disability takes into account the social part of the thing. So it could be it takes into account the person's work. It takes into account their job at their place of employment, or their job responsibilities at their home. If they have chores and responsibilities at home, then we consider that their work. That's their occupation. Or if they have things that they do in the community, like if they have to go shopping for themselves, or they go to church every week, or they go to bingo with their friends. Those are things that they do in society. So disabilities are things that are tasks that have been changed, that they do every day in society. So let's give some definitions. An example of a disability would be, let's say, unable to bathe toddler in your bathtub. That's pretty specific. So let's break that down. Let's say your medical diagnosis may be, let's go all the way to the beginning. Your medical diagnosis may be low back strain or lumbar disc herniation. If you don't know what that means right now, don't worry about it. It just means low back pain. Well, then your physical therapy diagnosis could be low back pain. Well, then let's go back a few slides. Let's do this all together. Your impairment would be low back pain. Your functional limitation could be inability to stand for more than 30 minutes, or inability to walk long distances, or inability to bend over and pick up things off the floor. Those are limitations. Where your disability could be unable to bend over and bathe your toddler in the bathtub, a functional daily chore that they have to do, or unable to complete lifting tasks at work. Maybe because of their injury, they can no longer perform their job description. So that's now a disability for that person. Look at this one, unable to throw a baseball. Now, I can't throw a baseball to save my life. I can make it go through the air, but it's not going to go where I want it to go. But that's not a disability for me now, because I can't throw a baseball. Now, if I am on a sports team, if I play for the Astros and I hurt my shoulder, and then I have to have rotator cuff surgery, and now I'm out of the game because of shoulder surgery, I can't throw my baseball. And because of my job as an Astros player, that's my disability now. I can't throw the baseball. But for me as an everyday Joe, no pun intended, that doesn't need to play baseball every day, and that's not part of my everyday occupation, then that's not a disability. Here's one that gets us all: unable to shop for groceries. So let's take that. Let's go all the way back to the beginning with that. Your physical therapy diagnosis could be, or let's start with your medical diagnosis. Medical diagnosis has to be a pathology. So let's say medical diagnosis was a right knee replacement. So that's a knee replacement. Our physical therapy diagnosis may also be knee replacement, or it could be abnormality of gait, lower extremity weakness, impaired balance. Our impairments would be weakness, pain, decreased coordination, increased inflammation. Our functional limitations for that might be inability to ambulate, or inability to stand up on the surgery leg, inability to get in and out of the car because of maybe decreased strength. And then the disability could be maybe unable to shop for groceries because of your knee replacement, because of whatever your impairments are. You can't walk through the whole store and shop. So you have to get somebody to do it for you. Or unable to attend church because of pain, weakness, decreased flexibility, whatever the impairments are. You can't do something that's functional or a chore or part of your daily or personal occupation or part of your community occupation. So that's what disabilities are. So those can be really, really, really hard to keep together. Okay. Now you do have an assignment on this where I'm going to give you, and it is on Blackboard, and it's labeled the ICF assignment. It stands for International Classification of Functioning. And that has to do with pathology, impairment, functional limitation, and disability. And there's going to be a sentence, and you have to write out to the side. You can just write the letter it starts with. You can write D for disability, I for impairment. You can write FL for functional limitation, or P for pathology. But there's some examples I give you, and I think there's like 25 or 26. But that's due, and the due date is on your schedule. But you will turn that in on Blackboard. There's a submission link for that. Okay. Don't wait till the last minute to do that, because you need to start learning how to tell these apart. So maybe try the worksheet and do it on a separate piece of paper and see if you get it. And then maybe go through this PowerPoint and go through your textbook, and then see if you read through it again, and then try the worksheet again and see if it's easier for you. I will tell you that this is keeping these straight is a little challenging for everybody coming into the program. Even PT schools, we have to keep these things straight, and it is kind of confusing, but as time goes on, it's going to make more sense. But make sure you get these in your head now. The faster you do, the more it'll make sense. What is a prognosis? Prognosis is the prediction that we make on many factors, but on how well you're going to get, on your chance of recovery. So patients are always going to ask, am I ever going to walk again? Or how long is it going to be till I walk? If you say, well, based on my experience, with your weakness and with knee, if they say they had knee replacement, you should be walking normal in this many months. Or if they had a spinal cord injury, your prognosis may be, we don't know if you're going to be able to walk again. Our prognosis is poor, meaning you probably won't walk, but that doesn't mean we're not going to try. We're going to try it. And we never just don't do things with people because we don't think they're going to be able to do it, or because the book says. We do things for people even if science says we can't do it, because there's always going to be things that happen that the body that's not supposed to happen when people are healing. So things happen that people call miracles, or people defy the textbook and heal or get better in a way they're not supposed to. It happens sometimes. Sometimes they blow our prognosis out of the water. Sometimes they're right on the money, and sometimes our prognosis is a little bit higher than what they actually made. And if that happens, that's okay. In our world, we generally say poor prognosis. Fair prognosis might mean they can make some gains, but they're still going to have some limitations. Good prognosis might be most of the factors are pointing in their favor. And excellent prognosis would be like everything is in their favor with their pathology at the state it's in. They're probably going to make 100% recovery. Interventions are what we do to make a change or an outcome. So any exercise we do with an intervention, that's a therapeutic exercise. Modalities are things like hot packs, cold packs, electrical stimulation, ultrasound. Those are modalities. Those are interventions. Manual techniques are things we do with our hands, like stretching or joint mobilizations. Gait training is teaching people how to walk again. Transfer training is learning how to get in and out of your wheelchair. And any education that we ever teach any patient or family member, whether it's about their pathology, their condition, how to do a new skill at home, or just their home exercise program, that's all education. Their discharge. There have to be indications for discharge before somebody can be formally discharged. So at a time of an evaluation, when the PT does their exam and evaluation, we're going to set goals for the patient. We're going to set long-term goals and short-term goals. And as time goes on, say at every reevaluation, so every 3 to 4 weeks, we may modify those goals slightly just to make this as per the way the patient is going. So if the patient is meeting their goals fast and still has a lot to work on, we can make harder goals. If they're going really, really slow in their therapy, we may want to back off on some of our goals and make them a little bit easier and make it more likable for them to reach. Not likable, make it more likely they'll reach their goals. So that's whenever people will be discharged, if they've met their goals. Another time to discharge somebody is if there's a lack of progress. Now, that means if they've been seen for several sessions and nothing is changing in any way, then that's not, we can't really keep seeing them anymore. We can't just keep charging their insurance or charging them cash pay or letting them pay their copays and us doing things with them when nothing is changing. So we've got to see change every week. We've got to see change. No matter how often you're seeing them, we've got to see change happening to justify seeing them. That goes into the next one. Service is no longer justified. So justified means that when we see somebody in therapy, they've got to have a skilled clinician seeing them. That means that whatever they're in therapy for, they've got to have the skilled brain of a PT or a PTA for them to be seen. Okay, that means that their injury or their pathology is bad enough that they've got to have a skilled professional to deal with that. Now, if somebody just, if an athlete sprains their ankle and they've done it 10 times before and they know how to wrap it and ice it, then those services really aren't justified for us. They may work with their athletic trainer on strengthening, but if they've done this before, they probably won't go through a lot of PT. So they might see us once or twice, and then they're good. They're on their own after that. That service is no longer justified. If there's a lack of progress for a long time, we can't justify our services. And if the patient requests that they be discharged for any reason, it could be they don't want to continue therapy, or maybe it's maybe they are having problems financially, maybe paying their copays is coming to the therapy a lot. They can't afford the copays, or their insurance is stopping paying for their therapy. They've run out of visits and they can't afford it anymore. That's a time to discharge somebody if for a payer reason. If the patient just says they don't want to take your advice anymore and they give up, I mean, it's their choice. Now we have to, as professionals and as skilled professionals, it's our job to educate them and tell them the importance of what we do. But if they flat out just don't want to do it anymore, or they request to see another therapist, we have to comply with that. Yeah. Test and measures. If test and measures don't change, so like if strength scores are never changing, range of motion scores are never changing, that's the time for discharge. These are just some trends that have been going on in the PT world, especially the last 10 years, especially since we've been getting more big into having direct access to PTs. PTs are getting big into the health and wellness business now. So besides just treating patients that are already sick or injured, a lot of PTs and PTAs are getting into the health and wellness promotion business, maybe working for gyms or working for senior centers, or maybe working for school districts, or just something where they may be like the facility guru for health and wellness, or the company guru for health and wellness. And they may do, they may do exercise programs for the facility or the corporation. They may do ergonomic assessments, but it's not anything to fix any kind of pathology. It's just something to help keep everybody healthy and keep them from getting hurt. Disease prevention, this goes right along with that health and wellness promotion. We're always trying to teach people about a healthy lifestyle. And so, we're not doctors, but we can, if we know our patient has high blood pressure, we can tell them the types of foods that they need to avoid. And if they are an obese patient, we can tell them the types of foods to avoid and the types of things they need to avoid while they're with us. If they have congestive heart failure and their legs swell because of extra fluid, which they usually do, we can tell them about salt intake and educate them on those things. So you'll learn all those things later. Don't try to learn them now. Okay, so this is the last slide. So if you have any questions on these, which I think you probably will, please email me before the end of the week and give me your specific questions. I pretty much can guarantee I'm going to have some questions on the assignment, and that's okay. I always do, and I want those questions because I want you to get the difference between pathology functional limitation, impairment, and disability. I want you to get those things down pat, okay? So try those things a few times, go through it in your book, and then if you need some more practice examples, I will be glad to give you more. But we'll start off on your assignment first, so try that. If you have trouble with it, give me a holler, and then we'll try to work through it together.